Wait. I mute everybody first. Then, Luffy, you please unmute yourself. Okay, I've already unmute. Can you please unmute yourself?
Okay. Hi, everybody. Okay. First, I would like to thank to Mr. Wong and Albert for arranging this meeting. So due to the MCO, otherwise, if no MCO, actually we can have a big gathering here. Because we have a space here, we can meet up and then we can know each other. That's much be better. But due to current situation, there's no choice. So this is a new way. So we do online education. So we start with first we have a Dr. Lingeswaran here. He's our nuclear medicine physician. He just joined us. I already know him from Beacon. He just joined us in Pantai, I think last month. So to start our presentation, so I would like to share just a brief about our center, PHKL, and our cancer center and nuclear medicine center. So I just share my presentation. Yeah.
You share screen. Share screen.
Luffy, you want to share your screen? I think I have to leave. You're showing a video.
Yes, a video.
Okay, can I make you co-host?
Yeah.
Okay, I make you co-host. Right. But Dr. Lingis, you have to unshare your screen first. Otherwise, it cannot. Yeah. Can I? Okay.
Okay.
So may I now?
Yep.
Okay. Is it? I'm going to play now, right?
Yeah, you are there, but you haven't get the file, I think.
Yeah.
Albert, you take over the meeting participants. I manage the rest.
Lufty, you have to click onto the thing.
Yeah.
Your virtual visit. You didn't click on it.
I just put a new share, right?
No, you just click on it, you will open.
Yeah, you can.
Okay.
Just click on to the virtual visit and you will open up.
Okay.
And that will do.
Where's mine?
Click harder, I think.
I think I lost here. Wait,
click harder. The virtual visit at the bottom. Fast. Well, we have 75. Now we are overspilling. That's good. We have 75 visitors. 75. That's good. That's the amount that was registered. So I think we're now getting more. Sam, yeah, why you raise your hand, Sam? Unmute yourself.
Hang on. Sorry.
Am I? Click on it. It doesn't open, huh?
Is it okay?
No, yes, but it didn't open. Your file didn't open.
The music is there.
Huh?
The music, you can hear the music. Huh?
No, we can't hear the image. Because we only saw your virtual visit cancer center, PHKL, but the
Yes.
file didn't open. Open it, yeah. You click it
Yes, hang on.
on the right hand side of your mouse. You just click it. Hard. Open. Open. Tak boleh. Cannot lah. Your file tak boleh buka lah. Maybe Lufti, I think we come to the back end now. Can we do that?
Okay.
You try to figure it out. We come to back end and
Okay, sure.
all right. Why not I introduce Dr. Lingeswaran, and I think his time is precious. A doctor, especially a consultant, and one of Dr. Lingeswaran is a rare breed lah. You know, he's a consultant physician, in nuclear medicine, and he practices both. Of course, we know in Beacon Hospital and Pantai Hospital, and Dr. Lingeswaran is really expertly trained in administrating PSMA Lutetium 177 for advanced prostate cancer and neuroendocrine tumors in Malaysia. He is one of the rare breed. And I remember when we met Lingeswaran about 3.5 years ago, when he just started in Beacon Hospital. He invited us together with Mary. Mary, of course, is the boss of Beacon Hospital. And he excited us with all his new treatment. As I said in my circular, Dr. Lingeswaran and Dato Ibrahim together, they brought PSMA to Malaysia. And it's about 2 years ahead of Singapore. Just imagine. And you go to Singapore, and of course, it's many years ahead of UK. I think UK is now struggling to use PSMA site, not because of anything, because they don't have money. I think in a private hospital, maybe, yeah, a couple of them. Okay. But of course, in Europe, PSMA is prevalent. Of course, Dr. Lingeswaran is really fortunate that he was trained in Peter MacCallum Hospital in Melbourne. And I also went for my treatment there. Or in fact, I went for my scan, PSMA scan, twice in Peter MacCallum. And of course, Peter MacCallum is a foremost in Australia. He's one of the #1 cancer center in Australia. And they are really doing a lot of pioneer work, you know, on PSMA. And without doubt, and they are using PSMA Lutetium 177 very aggressively, doing a lot of studies, published a lot of papers. And as I said, we are very fortunate that Dr. Lingeswaran did his fellowship there. And Lingeswaran hailed from University of Science Malaysia. He graduated in 2008. And then after that, he also get a specialist degree in nuclear medicine. Also University of Science Malaya in 2013. And of course, now he has so much experience on that and done a lot. Anyway, without ado, we would like Dr. Lingeswaran start off now. Okay. All right. Can we give him a round of applause? Okay. Go ahead, Dr. Lingeswaran. You have to unmute yourself though. On your left hand.
Okay.
Go ahead. Please.
Yeah. Can you hear me, gentlemen?
Yes. Yeah.
Okay. Thank you, Mr. Kwan Seng, for your kind introduction. Talking about Peter Mac brings back a lot of fond memories because I was there when we started off Lutetium PSMA in Australia. So without wasting much time, let's start the talk. So we will be talking about management of prostate cancer in the terms of theranostics. So I'm sure many of you would have heard the word theranostics when you Google online, because I find prostate cancer patients are one of the most updated. They read a lot, they know a lot about their disease. So basically theranostics is just 2 words, therapy and diagnostic. So when we talk about diagnostic, before we decide whether a patient is suitable for treatment, we need to do some scans. So naturally, in prostate cancer patients, we know that FDG PET-CT is not very sensitive in picking up disease. So probably those who have been having prostate cancer for, let's say, over a long duration, maybe more than 10, 20 years, I'm sure at that time of diagnosis, your consultant might not even have done FDG PET-CT for you. That is because not all cancers can be picked up by FDG. So we were lucky when Gallium-68 came into the picture. We started using Gallium-68 for neuroendocrine tumors, which itself is a very rare tumor. So down the line, we started exploring. So Gallium-68, we tagged it with a cold peptide we call as PSMA, prostate-specific membrane antigen. So the end result is we get gallium 68 PSMA. So gallium 68 PSMA PET is used mainly for the diagnosis, meaning to say for staging, restaging of prostate cancer. So especially when your Gleason score is high, most of the urologists and oncologists nowadays will request for a gallium 68 PET-CT, irrespective of whether MPMRI was done or bone scan is done, because we see a lot of disease being picked up when we do gallium 68 PSMA PET-CT. So that is I would say, the importance of having a gallium 68 PET-CT done. So once we have the gallium-68 PET-CT, when we talk about metastatic castrate-resistant disease, it also gives us another option for treatment. So in this case, for today's discussion, we are going to talk about Lutetium-177 PSMA. So if your gallium-68 PSMA PET-CT is positive, meaning to say we pick up disease there, technically we can treat you with Lutetium-177 PSMA. All right. So that is the concept of theranostics, diagnostic and therapy. We do everything and we see what we treat. So that is the important thing that we always say. Most of the nuclear medicine physicians will tell you we see what we treat. So if you look at the screen now, this is the pre-therapy PET-CT scan which was done. This is a gallium PSMA PET scan. You can see all the black spots in the bones, and this patient was deemed suitable for lutetium PSMA, and he was given lutetium PSMA. So this is a post-therapy SPECT-CT, basically a gamma imaging which shows that the lutetium has been delivered to all the disease sites. So what is PSMA? PSMA is, all cancer cells, all cancers will have specific receptors present on their tumor surface. So for prostate cancer, one of the most common receptor which is present on these cancer cells, what we call as PSMA. So PSMA is what we call as a transmembrane glycoprotein. It is highly overexpressed in prostate cancer, and usually in castrate-resistant metastatic disease, it's upregulated, meaning to say it becomes very sensitive in castrate-resistant disease. Hence, why we pick up a lot of disease when we do gallium-68 PSMA PET-CT for castrate-resistant prostate cancer. All right. So, what are the advantages? We can present lesions suspicious for prostate cancer with excellent contrast and high detection rate, because most of the time those who are doing imaging doctors like radiologists, nuclear medicine physicians, we have this thing what we call as, when we detect any lymph nodes or visceral disease, if it is below a certain criteria, below a certain measurement, we can't confidently call it as disease. But with the help of gallium-68 PSMA PET-CT, we have picked up disease as small as 0.2, 0.3 cm. That I'm talking about lymph nodes. So if it lights up on PSMA PET-CT, meaning it means definitely it's disease. It cannot be anything else. So there are times when patients with prostate cancer, we pick up disease up to the neck. We have patients with lymph node mets to the neck, even to the axilla. There was one interesting case. There was a patient with lymph node spread to the axilla. So gallium PSMA PET, without a question is very useful. I'm happy that a lot of consultants nowadays have switched to Gallium PSMA PET-CT. So it is a good improvement, and also with further reduction in price, I'm sure Pantai also will be looking into it. The cost of the scan used to be very high and is slowly coming down. So I think the more scans we do, the lesser the cost is going to be soon. So this is one of the earliest gallium PSMA PET-CT which was done in Germany. So if you can see, the PSA level is only 0.7, but you can see the extent of disease. It's very extensive, very small disease picked up on this PSMA PET-CT. All right. So this study which shows at that moment, the most common imaging was what we call as carbon-11 choline PET-CT. So the sensitivity of PSMA when it was compared to choline PET-CT, you can see on the screen, if with PSA levels of more than 2, you can pick up almost 96% of the disease, compared to a choline PET-CT where you only pick up about 62%. And this is just further describing the positive findings where you see 90% of the patients will have a gallium positive disease. This is just further example of tiny disease which was picked up on the PET scan, what we call as a sub-centimeter. Sub-centimeter means less than 1 cm lymph node. Okay, and gallium PSMA definitely outperforms choline PET-CT in detecting prostate cancer. And here on the screen above, this is a gallium PSMA PET scan. You see one focal lesion there. Compared to a fluoromethylcholine, you see a diffuse uptake. So diffuse uptake is sometimes difficult to say whether it's disease or it's just a normal uptake. And this article here describes one of the earliest studies which was done with lutetium. This was done by Prof. Ahmad Zadafar in Germany. So he was one of the pioneers there as well with regards to lutetium PSMA treatment. And you can see the results. The PSA decline was detected in 70% of the patients. This was one of the earliest studies which were done at that point of time. So I will talk briefly about lutetium PSMA because most of the time when I see patients, they would have read up about lutetium PSMA. Some of them have even read up journals about it. The most common question they ask me is, what is lutetium PSMA? What is the flow of events? What do you do? And all. So I thought it would be better if I describe that today with ladies and gentlemen. So before treatment, we need to make sure we have a gallium 68 PSMA PET-CT performed at least 1 month prior to treatment day. So meaning to say, the scan should be as recent as possible, keeping in mind that our order period for lutetium is usually about 2 to 3 weeks, because we get our lutetium supply from overseas. Beacon gets it from Holland. Pantai, I heard they are getting it from Turkey. So wherever we are getting it from, we need at least a downtime of 2 to 3 weeks for us to order the dose. So the gallium PSMA PET scan has to be done at least 3 to 4 weeks prior to that. And for now, lutetium PSMA is being used on compassionate basis, meaning to say the patients have failed all lines of treatment and there's nothing else to be done for them, and we consider lutetium PSMA. That is as we are talking now, but I'm quite confident things will change soon, with a lot of studies being taking place in US especially. So usually if there's US FDA approval, most of the time the insurance companies will also come in and they will consider lutetium PSMA. We'll talk about it more later on. There are some questions which have been put up by some of you gentlemen. I'll be answering it later. So back to the pre-treatment preparation, there has to be evidence of metastatic castrate-resistant prostate cancer, meaning to say that they have failed all treatment and we are considering them for the next stage. So we need to do some blood investigations, at least a full blood count, liver function test, renal function, and also your baseline PSA level, which is important for us. And on treatment day, you don't have to fast. You can have your light breakfast, drink a lot of fluids in the morning of treatment. For the treatment per se, just before the treatment, we usually apply some cold ice packs over the salivary glands because there's always a lot of uptake in the normal tissues. So one of the normal tissues, normal uptake involves the salivary glands, what we call as your parotid glands, your submandibular glands, which will accumulate a lot of lutetium. So we need to cool down because you will tend to develop what we call as sialoadenitis. So to reduce that, we usually apply cold ice packs at least 30 minutes prior to the disease and about 3 hours thereafter. And lutetium PSMA is actually just 5 to 10 minutes slow injection given intravenously. So there's nothing big to prepare. It's just some hydration which is given over a drip, intravenous drip. And I come in and usually we'll give the injection slowly over 5 to 10 minutes. Most of the patients will mention that sometimes when the lutetium is going in, they have like this sort of like burning sensation, which is quite common, but it is not long lasting. It's just at the moment when the lutetium is being pushed into the IV line. With regards to renal protection, lutetium dotatate, which we use for neuroendocrine tumor, we need to give what we call as renal protection. But in lutetium PSMA, we don't need to do that. So that saves us at least about 3 to 4 hours. The renal protection protocol takes about 3 to 4 hours, which is not needed for lutetium PSMA because it is the tagging capacity of lutetium to PSMA is very high and it's very specific. Hence, we don't have to worry so much about renal toxicity. And we do our post-therapy scan the following day, 24 hours later. Post-treatment, as with any nuclear medicine treatment that we always advise to our patients, unless you are on fluid restriction, drink a lot of liquids, because whatever lutetium we give, it goes to the cancer cells. Whatever not taken up by the cancer cells has to find a way to come out. So how it comes out is through your bodily secretion, your urine, your feces, your sweat, and all. So it's good to have a lot of fluid intake so that whatever is not necessary will be washed out from your body as soon as possible. And also when you go to the toilet to pass urine, always make sure you sit so that you don't splash or spill your urine around the toilet bowl. And for flush water 2 to 3 times and wash your hand thoroughly. Just for the same reason as I said, lutetium comes out of your body and we won't be able to see it with our naked eyes, but it is around there. So the radiation is good for you, but it's not good for people surrounding them, meaning to say your family members as well. So to minimize these radiation exposures, we tell, make sure, for example, even your clothes, you collect your clothes for 1 week and you wash it separately at the end of the week. Even your plates, your cups, for 1 week, use the same plates and cup and then you wash it separately. It will be safer so that there's nothing, no mixing around with other family members. You can stay in the same house as your family. Just make sure you have a distance of at least 1 to 2 meters away from people around you. All right. Common risk side effects. Any treatment for that matter, whether it's chemotherapy, radiotherapy, or whatever it is, there are side effects. The common side effects with regards to lutetium PSMA is usually reduction of white cell count, hemoglobin, and platelet levels for 3 to 5 weeks after therapy. And the levels should return to normal by 8 weeks after the therapy. But in some cases with extensive bone metastasis, meaning to say that cancer has spread to the bones extensively, this is going to be a challenge for us. Because from what I've seen over the past 4 or 5 years that I've been involved in lutetium treatment, our biggest concern is always platelet levels. So platelet levels always take what I would say is platelet levels will be the first to be affected. That is because there is already some bone marrow suppression when we are giving lutetium to kill the cancer cells in the bones. All right. So if there are only few bone lesions which are present, then it's not a big problem because you have what we call like sort of a reserve, a marrow reserve there. But if there is extensive disease in which sometimes can occur in advanced stage, the challenge comes in there. So we need to manage your platelet levels, your hemoglobin, white cell usually okay. Your platelet levels are the one which I always emphasize to my patients that we have to keep a close eye. So that's the reason why right now what I do is every 2 weeks and 4 weeks after treatment, I will monitor my patient's full blood count. And the other side effect, we'll talk about it later. Another one which some patients do mention is temporary worsening of bone pain shortly after the treatment, which a phenomenon what we call as a flare. This usually occurs within the first 3 days of therapy, and it can be treated with pain medication. But in most patients, they tell me that after lutetium administration, their pain has reduced. So immediately after lutetium or the following day. So sometimes it can be psychological and can be also might be the truth as well. Okay. Another side effect that we have to keep in mind is xerostomia, or what we call as dry mouth, resulting from reduced or absent saliva flow. Okay, this happens because remember I did mention about the salivary glands that we have, the submandibular, the parotid glands that we have. It can be affected during lutetium treatment. So because of that, you can have dry mouth, but out of many patients that we have treated so far, not many really complain of dry mouth due to lutetium PSMA. So bone marrow toxicity requiring transfusion and other treatment in extensive bone mets, yes, we do have, but it's quite rare. Infection, touchwood, so far I've never had any patients going into septicemia or any sepsis and they're requiring antibiotics. Reduction in kidney function, so far never. In fact, I would say the best patient who have responded to lutetium surprisingly is a patient with moderate renal failure. So this is a patient from US who has failed all other treatments. He came down to Malaysia to try lutetium, and he is someone who I would say is radio sensitive. The moment I gave him one cycle of lutetium, the disease disappeared because he had a lot of visceral disease and a bit of bone disease. After one cycle of treatment, the disease disappeared, but obviously it comes and goes. So the good thing about this lutetium treatment is we don't have to do it like a regime. You have to do it every 6 weeks or every 8 weeks, and whether your PSA is zero or not, you still have to continue. We don't do that. What we do is usually once we give the treatment, we see how you respond to it. So PSA response sometimes can take time. Most of the patients, we see a response within 4 weeks. Anything before that is usually unreliable. So if after 4 to 6 weeks and we don't see the PSA coming down, then I usually tell the patients there's no point in continuing lutetium treatment. Because most of the centers, yes, we do 6 to 8 weekly all over the world. We do 6 to 8 weekly of this lutetium treatment, and we reassess the patients at the end of the 6 to 8 weeks, which means 4 cycles, 6 to 8 weeks apart. It comes to about 6 to 8 months. But in Malaysia, the reason why I don't do that regularly for all patients is because the cost of lutetium is high. So I have to always keep that in mind. And I always tell my patients, I take one cycle at a time. Let's see how you respond. And then we go on to the following cycles. Okay. So this, with regards to kidney function, there's nothing much to worry. liver function as well, there's nothing much to worry. So the only thing that I always keep telling everyone is your marrow, bone marrow function has to be always watched closely. All right, so now we're going to just look at some examples of patients that we have treated, how they responded, and all. So these were one of the few earlier cases that we have treated. So this patient had multiple bone and small lymph node mets, which you can see on the right side of the image. And he received 2 cycles of lutetium, and you can see it has almost disappeared. All right, so you don't see anything. On the left side of the screen, you can see another image where you don't see the black spots that you were seeing earlier. And this patient only had 2 cycles of lutetium. He definitely, the disease came back around probably 8 to 12 months later. But as I always mention, when you are coming for lutetium PSMA, you always have to keep in mind, you are not a stage 1 disease. You are already in stage 4. So stage 4 meaning to say that whatever we are doing is we are doing to control your disease and also to make sure that you have good quality of life. So we have to make sure that we keep that in mind when we're treating. So it's not surprising to see patients who respond to 1 or 2 cycles, we stop treatment, and what we call as they have biochemical recurrence after 3 to 6 months, and we retreat them. All right, so it is a dynamic thing. It's not just like we give 1 or 2 cycles, the moment everything is done, PSA goes up again, and that's it, we close shop. We don't do that. All right, this is another patient. We have also given 2 cycles of treatment. You can see here he had extensive disease, all these black spots on the right screen, and after 2 cycles it reduced. So we watched, we sort of like used the approach of wait and see, just monitor the PSA and then retreated him when the disease was most severe. So this is another patient who had extensive disease. He had multiple lymph nodes, lung and bone mets. You can see here the extensive disease. And after 4 cycles of treatment, it has significantly reduced in extent. And this is one elderly gentleman from Malaysia that we treated. He refused surgery, he refused all this hormonal treatment, radiotherapy, chemotherapy, and we tried giving lutetium PSMA to this patient. If I remember correctly, I think he received about 3 cycles. But unfortunately, he didn't respond in the sense that the disease was persistent. So we couldn't retreat him because of that. Because if you see on the screen, this is the patient that I'm referring to. You can see the big lymph nodes here, which remain static. The disease did not progress per se in terms of imaging, but it just remained static. So in this sort of patients, definitely we had to look for other alternative treatment rather than continuing with lutetium. And this what we call as dosimetry. So this is like what we call as when we are treating with lutetium PSMA, we want to know how much of it has been delivered to the cancer cells. So this is one of the studies which was done by Prof. Michael Hoffman in Peter Mac. You can see a patient with adrenal mets. He received at least about equivalent dose of 68 grays to the adrenals and also to the bone mets. So current trials, this is the interesting part because some of the question and answer session later, one of the patients have asked, so do you think that lutetium PSMA can come forward? I mean, meaning to say you give lutetium first before you consider other treatment. Right now, what we have is we have a 200 patient multi-center phase 2 randomized controlled trial in Australia where they're comparing it with existing chemotherapies. So this study, which is still ongoing, what it is known as therapy trial, and another trial, what we call as vision trial, that will probably answer some of the questions, whether there is a role for lutetium PSMA to come before chemotherapy. So a lot of interesting trials are taking place all over the world, including US. So For your information, Gallium PSMA PET-CT has been approved by US FDA end of last year. Hence, it has been accepted by most of the insurance companies. So I'm not sure whether they have started covering in Malaysia. You need to check on that. Okay, so when we talk about this, after the trials, PSMA, TAT is referring to alpha therapy. So once we have tried lutetium PSMA and the PSA doesn't come down, or in other words, you're not responding to lutetium PSMA, what is next? If you have received everything, meaning to say you have received hormonal treatment, chemotherapy, radiotherapy, and lutetium PSMA, what is left is alpha therapy. So alpha therapy, the concept is it's similar to lutetium, but the range of the particles involved are smaller. Meaning to say, if lutetium has a range of 10 to 12 mm, alpha particles have a range of just 2 to 3 mm. Why it is important is because the damage that it does to the surrounding normal cells is lesser when you're using alpha treatment. So this is something which we are trying to work on it, but it will take time for it to come into Malaysia because we have been working on it since 2018 and we can't get suppliers to bring it into the country. So alpha therapy is quite promising, what we call as actinium-225 PSMA. Actinium-225 PSMA, there's also bismuth, another agent which is also known as the alpha emitting radioisotope. It has reportedly it has higher rates of double-stranded DNA breaks in prostate cancer cells. And as I mentioned, it has lesser tissue penetration and lesser side effect in PSMA negative cells, meaning to say the normal cells in the body. All right. So a lot of trials are taking place. We have very limited data as of now. One of the reasons is the supply of actinium is also very limited worldwide. So it's not as widely available as lutetium. So the only places where you can get any decent supply of actinium for now is Russia, Europe, some in Germany, and also in South Africa. And the cost involved is also definitely higher in actinium PSMA. So now I'll move on to some of the question and answer session. These are some of the questions that I've received from some of your members. So what is the difference between chemotherapy and this treatment? What does one treatment preclude the other? If not, which should come first? Okay, chemotherapy and lutetium 177, there are a lot of difference. Which comes first? For now, as we follow the guidelines, we do chemo first. Meaning to say, once you have come to the stage of metastatic castrate resistant, you're not responding to hormonal treatment, ADTs, we move on to chemotherapy. All right. No doubt some patients refuse chemotherapy. In this sort of patients, we do consider lutetium. So if we were to follow the guidelines, we should do chemotherapy. And if chemotherapy fails, you move on to lutetium. Okay. The main difference sometimes is also sort of like the regime involved, the side effects involved. In lutetium, the side effects are lesser. It's well tolerated compared to chemotherapy, but the side effects profile is almost similar to chemotherapy in the sense that I'm talking about your bone marrow suppression, your kidney and liver function. So these are things that we have to keep a close eye. Definitely during the period of chemotherapy, you go through a lot of other side effects that we can't deny. So which is a bit challenging for some of the patients. And when is the ideal time to do this? I think they are referring to lutetium. So the ideal time to do lutetium will be when you are staged as metastatic castrate-resistant prostate carcinoma. Meaning we say everything else has failed and there's no other options. We try lutetium PSMA. And is it advisable to do this as preventive measure? Definitely no. We don't do this as a preventive measure. What are the side effects? Side effects, as I've explained earlier during my talk, the three things that you have to keep in mind is your bone marrow function, your renal function, and your liver function. Renal function and liver function are rarely affected. Bone marrow function will be affected if you have extensive disease to the bones, meaning to say you have extensive spread to the bones. We need to keep a close eye. If you are the type you have visceral disease, what we mean as lymph nodes or soft tissue involvement, it's a lesser side effect in terms of bone marrow suppression. Please explain the quality of life and overall survival of this treatment versus, say, chemotherapy. Okay, quality of life, definitely lutetium has better tolerability. Meaning to say the whole treatment process itself, I would say is only the injection itself is only 5 to 10 minutes. And definitely we do some hydration prior to the treatment and post-treatment. So putting everything together is probably a 1 hour procedure, and there's not much of other events involved. You hardly have any nausea or vomiting. So far, I've never seen significant vomiting or nausea in most of my patients. So, and it is also easily controlled. All right. Symptomatic relief is one of the biggest advantage that I found with regards to lutetium versus chemotherapy, especially with for patients with bone pain. A lot of them do get pain relief when they undergo lutetium treatment. The next question, in Fortis Memorial Hospital in New Delhi, lutetium 177 is about USD 5,500 per cycle. Any indications we can follow this price here? This is a bit tricky because, you know, in Malaysia, we don't have lutetium. So all our lutetium supply comes from overseas. And right now, the only place we can get it from is Europe, and also Pantai is getting it from Turkey, meaning to say everything is coming from overseas. And the cost is high here in our country, mainly because the cost of lutetium itself. So if at all we can get our supply at a lower rate, and India produces and uses its own lutetium. So they rarely buy lutetium from overseas. So they have adequate supply, and you know everything else in India is usually cheaper. So probably that explains why their cost is lower compared to other countries. But comparatively, I think we what would say our price is reasonable if you were to compare to Singapore or even other Europe. In US, I think it can even go up to 50, 60,000 ringgit per cycle, same as in Europe, right? So I always believe with more patients, eventually the price will come down. Just like how our Gallium PSMA scans, when it started, it was 7,000 ringgit per scan. And then it came down slowly to 6,000, 5,000. I think now most of the hospitals are charging about 4,950. It is also coming down further in Beacon. So eventually, I think every other hospital is going to bring down their price, so which is good for the patient. Similarly, lutetium, the same thing will happen eventually. So in the next question is, in newly diagnosed high burden, meaning to say metastasis to the bone, the present treatment is ADT plus docetaxel or ADT plus abiraterone. Do you see lutetium coming as first-line treatment before docetaxel or abiraterone? My answer is yes and no. No, because the current guidelines will say that we have to try ADT first or abiraterone, and then we move on to other agents. So because in most of the in cancer management per se, it is not a single discipline involved. So we doctors work on a consensus. So that is why the guidelines are there. So right now what we do is we follow the guidelines. we try, the patients are managed based on the guidelines which are available, meaning to say the ADT is there, the docetaxel is there, the abiraterone is there. In the future, it might change when there are more studies coming up. We need randomized control trials like what is taking place in Australia right now. Remember, I mentioned about the therapy trial where they're comparing chemo versus lutetium. So if we see significant results there, then probably it might encourage our oncologists and urologists to switch to lutetium first. So it will take time, but it will come sooner or later. In radical prostatectomy, the urologist skill and patient's outcome makes him famous. So in lutetium, what are the criteria we should look for in doctor and medical center when choosing this therapy? I personally feel experience matters the most. Please make sure whoever you're choosing, whichever doctor you're going to is well trained and not just trained on ad hoc basis. Because sometimes some doctors ask me they want to come and train for 1 or 2 weeks. I usually turn them down because I don't believe you can learn everything in 1 to 2 weeks and then start off the treatment in your center. So please check on that. Make sure your doctors and the center is well trained and also well equipped to offer the treatment, because lutetium 177, it involves a very steep learning curve. After 4 to 5 years of doing this treatment, I'm still learning a lot of new things with regards to this treatment. So it is not as easy as it seems, where you just come, we do the PSMA scan, if it is abnormal, then we give lutetium. Giving lutetium is the easy part. What happens after lutetium is given is the tough part, where you need to manage the patients, the side effects, or how we want to proceed further. Okay, next question. A patient appears to be a good candidate for lutetium. He has PSMA-heavy disease in areas when compared to FDG scan. I think what the person is trying to say is this patient has FDG positive and PSMA positive. So it lights up on PSMA scan and also on FDG scan. And the patient receives lutetium treatment, but his post-treatment scan shows the lutetium has been delivered to all the cancer cells. After treatment, we noticed that the PSA did not decrease, but it has increased. Okay, definitely there are patients with such scenario. I have personally had a few patients who had both FDG and PSMA positive. We treated the patient, and after 4 to 6 weeks, we measure the PSA. The PSA keeps going up, it doesn't come down. Okay, the simple answer to that is cancer cells are very complex, especially when you have a heterogeneous population of cancer cells. In the sense, when your cancer cells are FDG positive and is also PSMA positive, it becomes more difficult for us to treat, because some patients, when they are treated from PSMA heavy, they become FDG heavy. So that is the problem. We can't really predict which patient is going to respond favorably and which patient is not going to respond favorably. So it is always, and I always believe PSA alone is not a good indicator, because when you are having what we call as metastatic castrate-resistant disease, PSA doesn't accurately reflect your disease extent. So I always personally believe that when we face such a situation, we look at the PSA and we, if possible, we repeat the scans. Meaning to say, in this sort of patient, you do the FDG PET scan, you do the PSMA PET scan, put all together, and you will have an idea what is happening. So that is the most important thing. Once we have done that, if the PSMA avidity is higher, and if patient is still having pain, let's say clinically it's indicated, then I will consider PSMA treatment. If not, I don't. I don't know. Another option in this sort of patients, if your PSMA PET scan is still positive, the next option is to try alpha therapy. Alpha therapy meaning to say your actinium or bismuth. Okay. So if lutetium fails, what other options are available? So alpha therapy, meaning to say actinium 225, Zofigo. Zofigo, yes, but Zofigo is usually effective in patients with bone metastatic disease. Okay, it is not indicated for patients with soft tissue disease, meaning to say you have lymph nodes, you are spread to liver or lungs. It won't be effective in those sort of patients. So if you have only bone metastasis, Zofigo will work, but there's not much studies done to compare Zofigo with lutetium, because Zofigo is a sort of alpha therapy, lutetium is more of a beta. So it's totally two different modes of action. So the simple answer to that question, yes, actinium is interesting, but difficult to source. All right. So for prostate cancer recurrence with oligometastasis as per Gallium-68 PSMA approaching metastatic CRPC, will you suggest lutetium instead of abiraterone, enzalutamide, or apalutamide? Again, I would say I wouldn't suggest that for a simple reason, because when you have a disease, you have multiple treatment options. It is not a matter of which is the latest treatment which has to come first. I don't believe in that. What we need to do is we have to take step-by-step approach. So typically, if you're the lucky type, when your disease is just localized to the prostate, I'm sure you know that we go for the surgery or we go for the radiation treatment. If it doesn't work, PSA is going up, they start you on hormonal ADTs. It will sort of like control your disease. And eventually, when you come to a stage where it is not controlled by anti-hormonal, that is where lutetium should come in. I don't think lutetium should overtake the other mode of treatments as of now. And does Malaysian insurance company pay for lutetium treatment? In this case, so far, AIA and Great Eastern have responded positively. So I think this is mainly because end of last year, Gallium PSMA PET-CT was given US FDA approval for for prostate cancer staging. So with that, I think now the insurance companies are a bit more open. And last month, we were able to get one of the insurance companies to fully subsidize the treatment for one of their patients, meaning to say the insurance company paid the full amount for the treatment, which is 33,000. So if I think the next step for Prostate Cancer Society that I would suggest is please approach the insurance companies and make them pay for the Gallium PSMA PET scan. They should be paying because all the while they have been giving, their excuse is always, if it is not an FDA approved imaging modality, we won't cover. So now there's no question about it. It is approved by US FDA. The next is lutetium PSMA. Lutetium PSMA, a big trial is taking place in US right now. We are expecting the results to come out soon by this year, and I'm pretty sure that it will be soon approved by US FDA as well. So, which is good for our patients. And another question that I received, for the 350 cycles of lutetium treatment that I have done, what is the success rate? Okay, 350 cycles that I've done, it includes the treatment that I've done for neuroendocrine tumor and prostate cancer. So neuroendocrine tumor is also a big subset of patients who have received lutetium treatment. They do not receive lutetium PSMA, they receive lutetium dotatate. So that is a totally different story. But for prostate cancer, our overall survival is comparable to other treatment centers worldwide. Meaning to say, if you're the type who respond, your what we call as a PSA responder, where you have a decrease in PSA levels more than 50%. Typically, the overall survival in this sort of patients is usually 12 to 16 months versus 7 to 8 months for non-PSA responders. This is what we call as a median result rather than like an absolute number. So most of the treatment centers we see the same, but the side effect profiles are definitely different. In Australia, we were not so concerned about the bone marrow suppression, I would say, because I rarely see patients having their platelet counts dropping all the way below 10. Here, I have seen patients with PSA level, with platelet levels of less than 10. So the challenges we face in different parts of the world are different. In Malaysia, what I see always is the bone marrow suppression which comes in, and it usually can take some toll on it. But one of the patients, in fact, actually, recently there was this thing which was introduced to us, Revolade. Revolade is something which is used by the hematologist for treatment of patients with leukemia. They use that agent to boost your platelet levels. So this has been found useful in patients with low platelet levels. In fact, one of my patients that I treated recently, he has also what we call as a baseline low PSA level. And this patient, we have put him on Revolade, and his his platelet levels are holding on. So meaning to say, at least now, moving forward, we have an option where if really we need to treat this patient with lutetium, they have extensive bone disease, we can also start Revolade in this sort of patients to monitor their platelet levels. So the last question, I think I will probably leave it to Mr. Lutfi to answer. So I think I've ended my presentation with that last slide. Thank you so much for listening to me. Probably if there are any questions, I don't mind answering them.
Dr. Lingeswaran, you see there are some questions from the chat side. Maybe you can answer some of the questions.
Okay, I'm just looking at it. Just
at the bottom there, yeah.
Yeah. Okay. So let me start from the top. What's the difference in the facilities between Pantai and Beacon? Very good question. Okay, Beacon is a full-fledged cancer treatment center, but of course, in terms of equipment, we have Facity, but we don't have what we call as a Facity, meaning to say a gamma camera. A gamma camera is important for us when it comes to post-treatment. So once we have done the lutetium treatment, I need to know whether the treatment has been delivered to the correct place. I need to do a gamma imaging. Okay, so that I need to do it elsewhere. Right now, what I do is I'm sending my patients here to Pantai to do my post-treatment scan. So all my patients from Beacon, I send them to Pantai to do the scans, and I look at the scans here in Pantai. And in terms of facilities, I'm sure you know Pantai definitely has